Hi, we're going over Chapter 9 today. So in Chapter 9, we review head and neck anatomy. The first thing we look at are the regions of the head. It's divided into 11 regions. The frontal, parietal, occipital, temporal, orbital, nasal, infraorbital, zygomatic, buccal, oral, and mental. So those are the regions of the head. As you continue through this chapter, you're going to encounter references to these regions of the head. The bones of the skull are the cranium and the face. The skull is divided into two sections. The cranium is composed of 8 bones that cover and protect the brain, and the face consists of 14 bones. So in the human skull, the female skulls tend to be lighter and smaller, and they have thinner walls. Their foreheads retain a rounded anterior contour, and they have smaller teeth with rounded incisal edges. In male skulls, they tend to be heavier and larger and have more rugged muscle markings and prominences, while the teeth are larger and more squared incisally. The forehead is flatter as a result of developing frontal sinuses, which are larger in men. Bones of the cranium, they have single and paired bones. So the single bones include the frontal, occipital, sphenoid, and ethmoid bones. So the paired bones are the parietal and temporal bones. Those will each have 2 bones. And then there are auditory ossicles. So the 2 parietal bones form most of the roof and upper sides of the cranium, and they're joined at the sagittal suture at the midline of the skull. In the newborn, the anterior fontanelle is the soft spot where the sutures between the frontal and the parietal bones have not yet closed. The spot disappears as the child grows and the suture closes. So then they no longer have a soft spot, but they have what are called sutures, where those bones have closed up and that soft spot goes away. The occipital bone forms the base and the back of the cranium, and it joins the parietal bones at the lambdoid suture. The temporal bones are paired bones that form the sides and the base of the cranium. For the ethmoid bone, it forms part of the floor of the cranium and the orbit and the nasal cavity. The sphenoid bone is made up of a body of paired greater and lesser wings, and it forms the anterior part of the base of the skull. And auditory ossicles are the middle ear is composed of 3 tiny bones named the auditory ossicles. Each ear contains 1 malleus or a hammer, incus or an anvil, and stapes or a stirrup. These bones transmit vibrations caused by sound waves from the eardrum, and that's how we hear. With the bones of the face, the bones visible on the anterior view of the skull include the following: the lacrimal bone, nasal bone, vomer, nasal concha, zygomatic bone, maxilla, mandible, and palatine bones that are technically not facial but are included. The palatine bones are paired between the maxilla and the pterygoid process of the sphenoid bone. The zygomatic bones are known as malar bones, and they form the prominence of the cheek and the lateral wall and the floor of the orbit. The zygomatic process of the maxillary bones extend upward to articulate with the maxillary, or with the zygomatic bone. The maxillary bones contain the maxillary sinus and the alveolar process of the maxillary bones to form the support for the teeth of the maxillary arch. The maxillary tuberosity is a larger rounded area on the counter surface of the maxillary bones in the area of the posterior teeth. It's also a useful landmark in mounting maxillary radiographs because it's a round bony projection that sticks out that you're going to look for when you're mounting radiographs. Two nasal bones form the bridge of the nose, and two lacrimal bones make up part of the orbit of the inner angle of the eye. These small thin bones lie directly behind the frontal process of the maxillary bones. And the vomer is a single flat bone that forms the base of the nasal septum. Nasal concha are on each lateral wall of the nasal cavity. They consist of three projecting structures that extend inward from the maxilla called the nasal concha. Each concha extends scroll-like into the nasal cavity. The mandible forms the lower jaw and is the only movable bone of the skull, and you need to know that. All other bones in the skull are stationary except the mandible. The mandible is U-shaped and it's the strongest and longest bone of the face and develops prenatally as two parts. In early childhood, it ossifies or hardens into a single bone. The symphysis is located in the midline and in forms of mental protuberance, commonly known as the chin. So when they refer to something mental in dentistry, they're talking about the chin. A mental foramen is located on the facial surface of the left and right between the apices of the first and second mandibular premolars. So a foramen is an opening that blood vessels and nerves pass through. So the mental foramen is the foramen that is on the chin. The hyoid bone is unique because it doesn't articulate or come in contact with any other bone. Instead, it's suspended between the mandible and the larynx, where it functions as a primary support for the tongue and other muscles. So this bone is shaped like a horseshoe. It has a central body with two lateral projections. So it's positioned in the neck between the mandible and the larynx, and it's suspended from the styloid process in the temporal bone of the temporal bone by two stylohyoid ligaments. In postnatal development, where we talk about at birth, the cranial vault is very large, meaning that where the cranium is at, the way it's designed, it's large and the base and the face are very small. So it gives like a cartoonish look to newborns. The reason the face lacks vertical dimension is because the teeth haven't erupted yet. So once the teeth erupt into the mouth, the face starts to elongate or get more dimension to it. Several bones in the skull don't fuse until after birth, and the mandible is in two halves at birth and fuses later, like I talked about a few minutes ago. With the temporomandibular joints, or TMJs, it's a joint on each side of the head that allows for movement of the mandible for speech and chewing. The TMJ receives its name from the two bones that enter into its formation, the temporal bone and the mandible. So the mandible is held attached to the cranium by the ligaments of the TMJ and held into position by the muscles of mastication. And they're made up by the three bony parts, the glenoid fossa, the articular eminence, and the condyloid process. So the capsular ligament is a fibrous joint capsule completely encloses the TMJ. This capsular ligament wraps around the margin of the temporal bone's articular eminence and articular fossa superiorly, which means the upward part of it or the top part of it. Inferiorly or below, the bottom part of the capsule wraps around the circumference of the mandible condyle, including the condylar neck. The articular space is the area between the capsular ligament and the surfaces of the glenoid fossa and the condyle. The articular disc, also known as the meniscus, is the cushion of the dense, specialized connective tissue that divides the articular space into upper and lower compartments. These compartments are filled with synovial fluid, which helps lubricate the joint and fills the synovial cavities. So that fluid is there so that when the bones move and the joint moves, it doesn't create friction. So that is a lubricant in that area. With jaw movement of the TMJ, it's called a hinge action in the first phase in the mouth opening. Only the lower compartment of the joint is used. During the hinge action, the condylar head rotates around the point of the undersurface of the articular disc, and the body of the mandible drops almost passively toward the backward. The jaw is opened through combined actions of the external pterygoid, digastric, mylohyoid, geniohyoid muscles, and the jaw is closed by the action of the temporal, masseter, and internal pterygoid muscles. Gliding movement allows the lower jaw to move forward or backward. It involves both the lower and upper compartments of the jaw. With the temporomandibular joint, there are temporomandibular disorders. So there's TMJ is temporomandibular joint. TMD means temporomandibular disorder. So the two abbreviations obviously are very different. If someone has TMD, they might experience a disease process associated with one or both of their joints. So it doesn't have to be both joints, but it's called a temporomandibular disorder. It's complex and it can involve factors like stress, clenching, or bruxism, which bruxism is grinding. It can also be caused by trauma to the jaw, a systemic disease like osteoarthritis, or wearing due to aging. There are many different things that can cause temporomandibular disorders. And there are different categories of temporomandibular disorders that you can see on page 96 in your book. So with the categories of TMD, we have acute mastocytic muscle complaints, articular disc derangement, extrinsic trauma, joint diseases, and chronic mandibular hypermobility. You can have pain, joint sounds, limitations in movement with any of these as symptoms. TMDs are often considered to be related to stress. Frequently, oral habits such as clenching the teeth or bruxism are important contributing factors. Other causes of TMD include accidents involving injuries to the head, jaw, or neck, diseases of the joint, including several varieties of arthritis, and malocclusion, which is when the teeth come together in a manner that produces abnormal strain on the joint or surrounding tissues. So here we went over that you can have pain, joint limitations, joint sounds, and limitations of movement, and we went over the causes as well. So for muscles in the head and neck, we have 7 main muscle groups, which are listed here. We are going to go over all of these muscle groups. So with the major muscles of the neck, the 2 muscles of the neck are both superficial and easily palpated. Superficial means they're easily felt by your hands. So the sternocleidomastoid and the trapezius. So these muscles can become painful for you as a dental assistant if you are using improper posture or not using ergonomics. So the sternocleidomastoid divides the neck region into anterior and lateral posterior cervical triangles, and it serves as a landmark of the neck during extraoral examination. Your trapezius, or traps is what most people call them, lifts the clavicle and scapula, or your shoulder blade, like when you're shrugging your shoulders. So it's very important that you take care of your body and that you are sitting properly and standing properly when you're assisting, or you're going to make these muscles very tired and sore. When you have the major muscles of facial expression, the first one we go over is the orbicularis oris. It closes and puckers the lips, like if you were kissing. The buccinator compresses the cheeks against the teeth and retracts the angle of the mouth, like if you were sucking on a straw. Mentalis raises and wrinkles the skin of the chin, and pushes up the lower lip, like if you were pouting. And the zygomatic major draws the angles of the mouth upward and backward, like if you were laughing with your mouth open, laughing really hard. These are all paired muscles. So we have one on the right and one on the left. They originate on the bone and they insert on the skin tissue. So the seventh cranial nerve is what innervates the muscles of facial expression. For the major muscles of mastication, we have the temporalis, the masseter, the internal or the medial pterygoid, and the external or lateral pterygoid. The muscles of mastication are 4 pairs of muscles attached to the mandible. These muscles work with the TMJ to make all movements of the mandible possible. The mandibular division of the 5th cranial or the trigeminal nerve innervates all the muscles of mastication. On the muscles of the floor of the mouth, we have the digastric, mylohyoid, stylohyoid, and geniohyoid. These muscles are located between the mandible and the hyoid muscle, or the hyoid bone, I'm sorry. They work with the TMJ to make all movements of the mandible possible. Muscles of the tongue, we have intrinsic, so the muscles inside of the tongue that are responsible for shaping the tongue during speech, chewing, and swallowing. Extrinsic muscles assist in the movement and functioning of the tongue and include the genioglossus, the hyoglossus, styloglossus, and palatal-glossus. All muscles of the tongue, except for the palatal-glossus, are innervated by the hypoglossal nerve. The palatal-glossus muscle is discussed with the palate, and muscles of the tongue and the floor of the mouth are attached to the hyoid bone. Muscles of the soft palate have 2 major muscles, and they're called the palatal-glossus and the palatal-pharyngeal. The pharyngeal plexus innervates both of these muscles. So the palatal-glossus function is to elevate the base of the tongue, arching the tongue against the soft palate and depressing the soft palate toward the tongue. The palatal-pharyngeal forms posterior pillar and fosses, and it serves to narrow fosses and helps to shut off the nasopharynx. Now, the salivary glands produce saliva, which lubricates and cleanses the oral cavity and aids in the digestion of food through an enzymatic process. People don't realize how much saliva helps in these processes. Saliva also helps to maintain the integrity of tooth surfaces through a process of remineralization. So every time you put something in your mouth that is not water, the teeth go through a process called demineralization, where whatever is in that food or drink, it pulls the minerals, the calcium and the phosphate, out of the teeth. So then that food or drink pulls the minerals out of the teeth, the calcium and the phosphate. Saliva then enters the mouth, and there's calcium and phosphate in saliva. So then it remineralizes the teeth once the saliva hits the teeth. So the teeth are in a constant state of remineralization and demineralization when you are eating and drinking and pulling the minerals out, and then the saliva is remineralizing. So it's very important that we have a constant flow of saliva in the mouth to help remineralize the teeth. Also, so that it can help to break down the foods during digestion and lubricate and cleanse the oral cavity. So the saliva glands are classified by their size as either major or minor. So minor salivary glands are smaller and more numerous than the major salivary glands. You're going to find them in the tissues of the buccal, labial, and lingual mucosa, the soft palate, and the lateral projections of the hard palate and the floor of the mouth. Ebner's salivary gland is associated with the large circumvallate papillae on the tongue. When you pull out your lower lip, if you do that and wipe it off with a piece of gauze, you can see your own minor salivary glands in action, because after you dry the tissue, you'll see tiny pinpricks of saliva. Those little pinpricks of saliva are the products of minor salivary glands in action. With major salivary glands, we have the parotid gland. The parotid gland is when saliva passes through the parotid gland into the mouth through a duct called the parotid duct, also known as the Stenson's duct. You need to know these glands and ducts. The submandibular salivary gland releases saliva into the oral cavity through the Wharton's duct, which ends in the sublingual carnuncles. And the sublingual salivary gland releases saliva into the oral cavity through the sublingual duct, also known as Bartholin's duct. Now, the parotid salivary gland is the largest of the three, but it only provides 25% of the total volume of saliva. The submandibular gland provides 60 to 65% of the total saliva. And the sublingual salivary gland is the smallest of the three major salivary glands and only provides 10% of the total salivary volume. With the major arteries of the face and the oral cavity, they are listed here. And when you take your pulse in your neck, you are checking your carotid artery. With the major veins of the face and the oral cavity, they are listed here. The union of the temporal and the maxillary veins forms the retromolar vein. The external jugular vein empties into the subclavian vein, and the facial vein begins near the side of the nose. The deep facial vein courses from the pterygoid plexus to the facial vein, and the lingual vein begins on the dorsum, or the top, sides, and the undersurface of the tongue. When we look at the 12 cranial nerves, there are 12 pairs of cranial nerves all connected to the brain. These nerves serve as both sensory and motor functions. The cranial nerves are generally named for the area or function they serve and are also identified with the use of Roman numerals. So you will need to know Roman numerals 1 through 12. With innervation of the oral cavity, the trigeminal nerve is the primary source of innervation for the oral cavity. So that is the main cranial nerve that you need to know. Is cranial nerve 5 the trigeminal nerve? It subdivides into 3 main divisions: the ophthalmic, maxillary, and mandibular branches. The ophthalmic is not discussed in this chapter. So what you need to focus on is the cranial nerve number 5, the trigeminal nerve, the maxillary, and the mandibular divisions. The maxillary division of the trigeminal nerve supplies the maxillary teeth, the periosteum, mucous membrane, maxillary sinuses, and the soft palate. So it's going to subdivide into the nasopalatine nerve, the greater palatine nerve, anterior superior alveolar nerve, middle superior alveolar nerve, and posterior superior alveolar nerve. If you take note, this is a maxillary division. Any of them that have superior in them are going to be a maxillary nerve because it is on the top. For the mandibular division of the trigeminal nerve, we have the buccal nerve, the lingual nerve, the inferior alveolar nerve, which branches into the mylohyoid nerve, small dental nerves, the mental nerve, and the incisive nerve. Remember, inferior means below. So when you see something that says inferior, it is going to be on the mandible division of the trigeminal nerve. With lymph nodes of the head and neck, a dental professional has to examine and palpate the lymph nodes of the head and neck carefully during an extraoral examination. So that is going to be the doctor doing this examination. They're looking for enlarged lymph nodes to indicate infection or cancer. The lymph nodes for the oral cavity drain intraoral structures like teeth, as well as the eyes, ears, nasal cavity, and deeper areas of the throat. So lymph nodes are small and round or oval structures located in lymph vessels. The major sites of lymph nodes include your neck, which is known as the cervical area, under your arms, known as the axillary area, and in your lower abdomen, known as your inguinal area. The lymph nodes of the head are classified as superficial, which is near the surface and easily palpated, or deep, which is very deep inside the body and not easily palpated. Superficial lymph nodes of the head are in 5 groups: the occipital, retroauricular, anterior auricular, superficial, parotid, and facial nodes. Head and neck carcinomas often cause lymphadenopathy, which is swelling of the lymph nodes. Palpation of swollen lymph nodes can be the first indication of a carcinoma of the head or neck, which is why it's very important for providers to do these extraoral examinations. The deep cervical lymph nodes are located along the length of the internal jugular vein on each side of the neck, deep to the sternocleidomastoid muscle. So we must palpate deep around the sternocleidomastoid muscle to feel the deep cervical lymph nodes. Lymphadenopathy is when a patient has an infection or cancer in one certain region, and the lymph nodes in that region will respond by increasing in size and becoming very firm. So that's when someone says they have swollen lymph nodes. The lymphadenopathy results from an increase in both the size of each lymphocyte and the overall cell count in the lymphoid tissue. With an increase in the size and number of lymphocytes, the body is better able to fight the disease. Lymphocyte cells are the body's main defense. So if a dentist notices that the lymph nodes are enlarged, they make it an appropriate referral to the physician. And the last thing are your paranasal sinuses. They're air-containing spaces within the skull that communicate with the nasal cavity. Their functions include producing mucus, making the bones of the skull lighter, and providing resonance that helps produce sound. The sinuses are named for the bones in which they are located. We have maxillary, frontal, ethmoid, and sphenoid. At times, you may have a patient come in that complains of a toothache, when in reality, it is a sinus problem that they are having. And that's because the maxillary sinuses are located so close to the roots of the maxillary teeth that sometimes they're overlaid, it looks like, on the x-rays. It looks like they're laying right on top of the apex of the maxillary teeth. So when the sinuses get infected and inflamed, the pressure from the sinuses sits on the apex of the maxillary teeth and puts pressure on them. It can make a patient believe or feel that they have a toothache when in reality it's a sinus infection, or vice versa. They may feel that they have a sinus infection or a sinus issue when it's actually a toothache. So we need to be careful when we are diagnosing our patients and make sure we are diagnosing them correctly.